that guides us, provides strategies for us to be able to manage that. At the same time, it is important to know strategies that we can use to be able to control or contain outbreaks in our various countries. So before I go on, let me introduce the panelists for today. So we have Dr. Moriketa, our Regional Advisor, Infectious Hazards from the World Health Organization, Regional Office based in Brazzaville, Congo, Brazzaville. We have Dr. Miriam Nanyunja, who is our Eastern and Southern African Regional Hub Coordinator, World Health Organization, Regional Office based in Nairobi. We have Fred Kapaya, Epidemiologist, Cholera Preparedness and Readiness. We have Professor Olainka Debola, who is our hot lead, Cholera IMST. We have Emmett Ken, who is from CSP. We have Malika Bohenia, who is a technical officer, OCV, based at the headquarters in Geneva, World Health Organization, and part of the GTFCC. We have Ida Mari Ameda, health specialist, emergencies from UNICEF, East and Southern Africa. We have Dr. Ramadan Otim Patrick, health emergency officer, also our incident manager for the cholera IMST at regional level. We have Dr. Abhishek Ramar from CSP. Catherine Makwe has been replaced. She's not present, by Mr. Sebastian Yenan from CSP, specifically coming from Nigeria. We have Rina Doshi Mendra, who is also emergencies immunization officer working with Malika, but based at the World Health Organization Regional Office in Congo, Brazzaville. And we have Anton Angaluki Anjanga, who is public health emergency specialist from UNICEF. So let me take you through the agenda for today. So before we start and going to the agenda, it is very critical for us to understand that the World Health Organization, during trainings and webinars such as this one, we adhere to the code of conduct to prevent harassment, including sexual harassment. So even as we do this, we actually recognize this as very important as we do our work. Our agenda for today, housekeeping, this is what I'm doing right now. We are going to have opening remarks from Dr. Moriketa. Thereafter, we are going to have objectives of the webinar. Then we are going to have an overview and role of the country support platform. This is going to be given by Dr. Abhishek Ramau. Thereafter, we're going to have national cholera plans from development to submission for approval. This will be given by Mr. Emmett Kenny. And then we're going to have guidance to requesting for CSP support for NCP development, as well as country experience sharing. This will be done by both Mr. Emmett Kenny and Mr. Sebastian Yenan. Then we're going to have chance for Q&A. After that, we'll move into OCV, and the OCV will be given as a continuous presentation. This will be given the first part by Rina, and then the second part will be given by Malika. Then we'll have Q&A, and after that, we are going to end our webinar for today. So regarding questions on the chat, so when you look on your screen, you have these features, the icons. The first one is on the use of the Q&A. So this one, you use it for questions regarding the topic and presentations. And only questions that will be in the Q&A will be answered during the session. However, we're going to give chance for live questions, especially to our Portuguese-speaking colleagues, so that they can ask their questions in Portuguese and can be interpreted for us to be able to provide answers. So I repeat, we'll give priority to the Portuguese speaking for the live questions. Regarding the chat icon, you use this chat feature for questions regarding IT or logistics. So questions about IT and logistics, you actually use the chat feature. I'd like to indicate that we have interpretation in English, French, and Portuguese, and you can actually access this by clicking the interpretation button, as you can see on the screen. So you click on interpretation and choose the language that you would like to hear. To hear the interpreted language only, click mute original audio. Also note that the interpretation of proceedings serves to facilitate communication and does not constitute an authentic or verbatim record of the proceedings. So only the original speech is authentic. Regarding live transcriptions, we're saying you can click on the show captions and the caption would appear on the screen. To close the caption, click hide captions. So as you can see the features on your screen. Now regarding the recordings, materials, we are saying that this session, this webinar is being recorded, and we take your attendance as consent to be recorded. So recordings will be shared after the session in English, French, and Portuguese. The session materials, including recordings, will be emailed to the participants in the days after the webinar. Also, we want to indicate that as we continue to improve our training programs, we value your feedback. A survey will be shared at the end of the session. We highly encourage you to share your thoughts and suggestions. Your input will help us to tailor future sessions to better meet your needs and expectations. So, ladies and gentlemen, this is how we are going to proceed today. And I encourage you to be very active, post your questions in the Q&A, and we'll give chance to live questions during the session. So at this point in time, ladies and gentlemen, I'm going to call upon Dr. Moriketa, our regional advisor on infectious hazards, to give his opening remarks. Dr. Keita.
Thank you so much, Dr. Fred. Thanks, everyone. Good morning, ladies and gentlemen. This is our second webinar in a series. Today, we are talking about two very important topics in line with the Ending Cholera, a global roadmap to 2030. These are development of National Cholera Control Plan, NCPs, and oral cholera vaccine as a cholera control strategy. The NCP is a national strategic document that provides a roadmap to cholera control and elimination at country level. Therefore, it's critical that all countries develop NCPs, especially those that are prone to cholera. Sadly, only 6 out of the 28 cholera-prone countries in the WHO African region have completed NCP development and have started implementation. Today, experts will orient us on the processes and procedures for NCP development, as well as the strategies for its implementation. I urge you to pay attention to this session. The use of oral cholera vaccine is an important additional measures that help to limit the spread of the disease during cholera outbreaks. To contribute to cholera control in a humanitarian crisis and in endemic countries. Understanding the procedures for acquiring these vaccines is very important. In this webinar, experts will update you on the necessary procedures including a discussion on factors that contribute to delay in approving requests. I would like to reiterate that the WHO Regional Office for Africa Emergency Preparedness and Response Cluster is committed to support member states in the development of NCPs and effective deployment of oral cholera vaccines. Our ultimate goal is to have a WHO African region where cholera is no longer a public health threat. I wish you a successful and a fruitful session. Thank you. Merci beaucoup. Obrigado.
Thank you very much, Dr. Mori, for those very encouraging opening remarks. We really appreciate those. And ladies and gentlemen, the webinar is now open. So I will proceed to give a presentation on the objectives of this webinar. So again, I am Fred Kapaya. I'm based at the regional office in Nairobi from WHO. I'm going to take you through the objectives of this second webinar, which is a webinar in a series of webinars. So our general objective or objectives, like has already been indicated, today we are talking about two topics. One is on NCP development and the other one is on OCV. So our general objectives, we are saying that we want to orient our member states on the importance of a national cholera plan at country level. Our second general objective is to orient our member states on the role of OCV in preventing and/or controlling cholera outbreaks. Our specific objectives, we are saying we'd like to orient our member states about the need to develop a national cholera control plan, also to provide step-by-step guidance for developing a national cholera plan, and to update member states about the support available for national cholera plan development. We also want to orient our member states on the two scenarios for OCV deployment, and also provide guidance on procedures for requesting for OCV for the two scenarios, including factors responsible for delays in approval. Our outputs, we are saying at the end of the webinar, our member states will be able to understand the procedures for developing a national cholera plan, and also our member states will be acquainted with the processes and procedures for acquiring OCV for preventive and reactive campaigns. Ladies and gentlemen, these are our objectives for today's webinar, and allow me at this point in time to call upon Dr. Abhishek to give us a presentation on the overview and the role of the country support platform. Dr. Abhishek.
Thank you very much, Dr. Fred, and good morning, good afternoon to all the colleagues who are attending the second webinar organized by the AFRO office. I will just put these slides on the presentation mode. My name is Dr. Abhishek Rimal. I'm the interim country support platform coordinator, which is the part of the Global Task Force on Cholera Control, and we are hosted by the International Federation of Red Cross Red Crescent Society. In the next 10 minutes, I'm going to take you through the role of what is country support platform. Maybe many of you know, and for many of you, it is a new thing, and also what are the role the country support platform is currently playing in different countries in supporting them with the development and the implementation of the National Cholera Plan. Okay, as most of you know, like we are still in the 7th cholera pandemic, which started in 1961. And the strain of the 7th cholera pandemic is still a major global health threat. It primarily is impacting vulnerable communities affected by conflict, climate change, malnutrition, displacement, and the areas with poor water and sanitation. In the year 2023 only, we have close to 30 countries which have reported cholera outbreak, which is a massive rise as we compare to previous years. Around 20 countries are sharing the border with those 30 countries, and which were among immense risk of a cholera flare-up in those countries. It is roughly estimated that out of 7.3 billion people, 1 billion people are at direct risk of cholera. And it is very evident a targeted multi-sectoral intervention can effectively control this major public health threat. So since it can be controlled and the disease can be averted, the Global Task Force on Cholera Control was formed, which tries to bring 50 different institutions who were committed to reduce cholera deaths around the world together with different governments. And they came up with a ending cholera roadmap by 2030, which primarily aims to reduce the cholera death by 90% by 2030, and plus, if possible, to eliminate cholera in at least 20 countries around the world by 2030. As time passed, it was recognized that the more support is needed at the country level so that the roadmap can be implemented more effectively, and that gave the birth of the country support platform. And in 2019, in the annual meeting of the Global Task Force of Cholera Control, the country support platform was endorsed, and currently it is hosted by the IFRC. The country support platform provides a multi-sectoral operational support as well as advocacy and technical guidance to the countries to develop, implement, to resource mobilize, as well as to monitor the National Cholera Control Plan. We primarily have three major outcomes. One is to support countries and to work with the countries to develop and implement the National Cholera Control Plan with a multi-sectoral mechanism. Second is to work with the countries and other developmental partners, how we can mobilize the resource at the country and with other development partners to fund the National Cholera Control Plan. And finally, try to analyze where are the gaps at the country level, if there is any training needs, and support those gaps with a consultant, with some deployment, with some training, so that the country can effectively implement the National Cholera Control Plan. So this is just the journey where we are. Like in 2019, the country support platform was endorsed. The inception happened in 2020. Unfortunately, this was masked by the COVID-19 pandemic. But since 2021, the country support platform is really working very closely with some of the countries in Africa and also in Asia to support countries in developing and implementing the National Cholera Control Plan. And in 2022, we were on the full swing, and now we are also exploring with some other countries, like if we can support more countries in this process. How the country support platform has scaled up the global efforts on reducing cholera death by 2030. We have already supported 5 countries in development as well as in the implementation of the National Cholera Control Plan. 5 countries have been supported in either the oral cholera vaccine preventive proposal or also sometime implementation of the reactive campaign. We have deployed already more than 43 experts in different countries to support countries to develop National Cholera Plan, their vaccine proposals, advocacy materials, training needs, etc. And country support platform have supported till now more than 21 trainings related to cholera. We have been primarily focusing on multi-sectoral coordination and advocacy, and in which we are trying to establish a multi-sectoral mechanism at the country level so that a holistic approach is formed in implementation of the National Cholera Plan. We have been also supporting countries in their OCV campaign and providing them technical support in together with Gavi and WHO in developing the preventive oral cholera vaccine multi-year plan of action, working very closely with the government in developing the ICG proposal for the reactive campaign, and also working them around the micro planning during the implementation process as well. We are still working to make life easier for countries who want to work on the cholera platform. So we have been also developing some tools, which is like WASP baseline field assessment tool. It was done together with Nigeria. We are also working on a very simple guidance how to develop the National Cholera Control Plan with a template, and also WASP costing tool, primarily focusing on the hotspot, like how much money is required to do improved wash in that area. So we are all in the process of coming out of these tools, which will be beneficial for the countries. We have also established a pool of technical experts to support countries through deployment if there is a specific request to the country support platform that in this particular area there is a gap at the country and they need some support towards the National Cholera Control Plan. We have already, together with the WHO, have worked very closely to do 2 OCV specific training, one in Africa and one in Asia. And now we have a senior research officer who is working very closely with the GTFCC Secretariat towards the cholera research agenda. We are also trying to put some of the repository together of all the research that has been done around the field of cholera so that it is beneficial for the countries. So where we are present, so if you see in the map, all the areas which are on green, we have a physical presence. There are our program managers in those countries, but it is not like we have restricted ourselves to those countries, but we have received in the past and continuously getting requests from different countries for some type of technical support. So we have been currently supporting Kenya and also in a discussion with Cameroon for the support. And there is a plan to potential expansion to Malawi, Nepal, and probably Uganda if the request is pushed through. CSP, the country support platform, have also elevated the advocacy through the visibility, because it is very, very important, like the global leaders understand the importance of investing in cholera. So in 2022, we have hosted a cholera side event at the International Federation of Red Cross Red Crescent headquarters as a side event of the World Health Assembly. We are also working with different media engagement strategies, so the need of cholera is well spelled out in the media. We are also co-leading the GTFCC advocacy task team with support of the GTFC Secretariat, so that the right types of advocacy materials, communication tools are available for the countries. And we are very, very privileged, like the President of Zambia have accepted to be the global cholera champion. The GTFCC Secretariat together with the CSP always explore opportunity to boost the advocacy effort through His Excellency around investment that is required for the eliminating cholera from the globe. We also develop some of the operational highlights so that people are aware what the country support platform is doing, what the GTFC Secretariat is doing, what are the upcoming opportunities. There are also materials available in the GTFCC website, and we have also updates regularly coming in the Twitter, and now it is called X @SecGTFCC. And I do hope like you guys can follow that as well, so that you can continuously get some information coming through it. So that's just a snapshot on the What is Country Support platform. What I would like to say, like, we are there to work with you to ensure like we have a quality national cholera plan, as well as how we can collectively contribute towards the global roadmap 2030. Thank you very much.
Thank you very much, Dr. Abhishek, for that very good and important presentation that you have given. And ladies and gentlemen, like was indicated in the opening remarks, we really need to look at this as an important, way in which we can manage to eliminate or control cholera in the African region. So we continue with NCP, and I'm going to call upon Emmett Kenny to give us a presentation on the national cholera plans, and is going to take us through from development to submission for approval. Mr. Emmett, you can take it up. Thank you.
Thank you, Dr. Fred. So my name is Emmett Kearney. I'm the Senior Officer for National Cholera Plans within the GTFCC's country support platform that Abhishek just introduced so well. I'm going to speak about NCP development, but largely we're going to look at quickly on where NCPs fit within the global roadmap. But the bulk of our time will be on what is an NCP, what makes a good NCP, why is it important critically, how is it useful to you? And then I'll use the remaining time that I have to dive into the process on developing an NCP. I mean, this is a topic that typically we have several hours, several days to dive in with countries. So I'll do my best to pull it together in 25 minutes. And then I'll hand over to Sebastian Yenin, who the CSP has worked closely with in Nigeria. They've spent a year and a half developing their NCP. He has a presentation, and then we'll both spend a few moments together discussing his experience before we wrap up on the CSP side and open up for questions. So from the global roadmap to NCPs. Abhishek just introduced the global roadmap, and you're probably familiar with the overall goals, the axes, and the idea of the NCP is to pull this global commitment down to the country level where the action needs to take place, and not just to the country level, but subnational level. And this is a critical component of the NCP development. So why do we need NCPs? Because the global framework isn't enough, right? We need concerted and agreed commitments at country level by all relevant stakeholders to engage, to do a lot of the work people are already doing, but often just to shift focus to specific areas, the PAMIs or hotspots, and we'll get into that a little bit later. So the first step in an NCP development is to get a country commitment. This is best done at the highest level of government, at head of state, vice president, prime minister level, because when that takes place, then it isn't simply a Ministry of Health led effort. This really needs to be a multi-sectoral effort. In one CSP country, in DRC, our colleague is working with many ministries, and I think there'll be 26 ministers at their NCP launch in a few days or next week. So, having that high-level commitment allows those running the NCP process to pull in the highest level, to pull in the commitments then at minister level, and then work with technical teams across ministries. And we'll come back to that a little bit when we talk about the different pillars. What else is critical? To have full partner engagement, to provide their technical expertise as they carry out the inception and development and then implementation. And we need donor commitment to support the national cholera plans that are developed. And this is a bit the point. We're We're not doing this process to simply have a nice document and put it on the shelf, right? This NCP process is meant to generate attention, energy commitment, and to be the start of the fight against cholera in a country, not the beginning or something to tick a box. And we'll get into that a bit more in a couple of slides. And when we're talking about leveraging an NCP, and this will take us, the next slide will be about the benefits. We can think about an NCP in so that strategic component, again, begins with that high-level political commitment, which then allows ourselves to take action and have the power to move the relevant actors, bring together stakeholders, to then identify the national goal, the overall goal, whether that's cholera elimination or cholera control, to then set strategic objectives of each pillar, and then to dive in, identify relevant targets, milestones, critically to clarify the coordination mechanism. I think a lot of colleagues on the call will have experience in cholera emergency response, where coordination mechanisms were pulled together. And I'm sure you have a lot of lessons learned, some good, some bad. The idea here is that this is done ahead of time, and it's for the short and long term. Related to that, it's important to clarify how these stakeholders will work together, what the roles are, what the responsibilities are, and to have a clear understanding of all stakeholders at all levels. So one thing that's important to point out here is we call it a national cholera plan, but it isn't simply the actors at national level. It's critical to pull the actors from districts, from states, from municipalities, who are going to bring the nuance challenges of their areas that might not show up in the quantitative data, and they need to be involved in these discussions. Again, to contribute, to make it relevant and impactful, and then to ensure we have ownership and work taking place on the ground afterwards. That brings us to the operational component, and that's how we get there. So that's once we've had these goals, we look at what activities would need to take place to meet the goals. We set some timelines. We cost the implementation of the plan, prepare relevant budgets. We identify who can do what where. And critically, we identify the mechanism to track progress, so the M&E framework. And this is something we spoke a bit about on the last webinar for Zambia's experience. Bangladesh and Zambia, two of the countries, since the roadmap was published, two of the first countries to publish their NCPs. The CSP program manager in Zambia worked with colleagues there on a midterm review, and some important lessons were learned because of the M&E, and yeah, they've refined the M&E plan to make it even more robust going forward. So that bottom text on the slide is that, you know, this national cholera plan really functions as the core document, and not only document. I mean, it's kind of it's the convening, it's the workshops, it's the bringing of people together. It's kind of the core movement to move the implementation, the advocacy, the political interest, moving resources, and to just push the national effort forward. So let's specifically outline some of the benefits of developing an NCP. First, and as the pictures illustrate, visibility, right? So, I mean, in the bottom picture, you see Dr. Tedros at the IFSC headquarters in a GTFCC and CSP event. And what you don't see is the global cholera champion, the president of Zambia, who was on the screen at that same event, trying to bring attention to the fight against cholera. And this also happens at country level when the NCPs are being developed and when they're being launched. At donor events, there is an opportunity to bring a lot of visibility to the cholera space and the relevant pillars within the fight against cholera. Bringing all of these actors together and not just, as I said, not just having it be seen as a health-focused initiative brings increased credibility. So you have, again, that's the importance, it's that virtuous cycle of getting that high-level commitment, getting as senior technical people as you can engaged, all the stakeholders engaged, so that what the process that follows is as credible as possible, so the output is credible, right? We could just hire a consultant to write an NCP in a few days, but then it has almost zero credibility, right? And also, as mentioned on a couple of slides previous, we also established a coordination mechanism for the long-term fight against cholera in the country and in the case of an outbreak. Advocacy and fundraising, yeah, again, we're talking about from a very high political commitment to the fight all the way down to costed activities. And you could also see that as a menu of sorts. Once you've had this full process, you then have in the hotspots or PAMIs within the country, you have a commitment of all the actors to work in these specific areas with specific multi-sectoral interventions in each. And in principle, this can then we can turn around and bring this to the relevant donors in each of the domains or across domains to say, look, this is what all stakeholders agreed on. How can you help us? What can we do in the next few years to meet these targets together? And finally, carrying out an NCP development, you have technical support and guidance from us, from the Cholera Support Platform, the Country Support Platform, excuse me, from the GTFCC technical working groups, from counterparts in other countries and within your region. So it's one of those, if you build it, they will come. The more effort that's put in, the bigger of a process and the more benefits you can expect. So quickly, what makes a strong NCP? Well, again, the most important, I think, concept to digest here, and one of the first things to take away from this webinar, is that this isn't a cholera response plan, right? This isn't. There are many of you who are dealing with cholera outbreaks at the moment. Fast moving, you need to be doing a lot of things quickly to save lives, right? And that's absolutely normal and important to carry on that work. The NCP is the opportunity to take a step back from the reactive approach when feasible, right? Not to take resources away from a response, but when feasible to take that step back and to engage in a process that includes the reactive element, but really focuses on that long term, working to prepare for and prevent responses and work towards those longer term goals of control and elimination. And to do that, we have these targeted and coordinated multi-sectoral interventions based on strong surveillance, based on working across the pillars and engaging with the communities. You see a bit the theory of change here, where the emergency wash and case management is critical, and that saves lives. The vaccination can also, the preventive vaccination can buy time. The reactive can also buy time. But we want to combine these elements and work for the long term. And we see long-term wash at the top there. We know that if a country and if cities, towns, regions within any given country meet the SDG targets, 6.1 and 6.2 of basic water and basic sanitation, or safely managed water or safely managed sanitation, we won't have cholera outbreaks. But we also recognize that those are very expensive, take a lot of time, and this is what one of the pillars is focusing on. So what are the attributes of a good NCP? Some of these I've already been hitting upon, but I'll take them from another angle here. a good NCP should be country-led, right? This shouldn't be, it shouldn't be the UN or other stakeholders leading it. It should be the governments in the driver's seat with support of all the other stakeholders. And yeah, so we ensure ownership and implementation. It should be multi-sectoral, targeted and coordinated from the highest level all the way down to the PAMIs or cholera hotspots. It should be integrated, building upon existing plans or programs. This is something that I haven't hit upon much yet, but I think it's important for us to acknowledge that the National Cholera Plan, we're not really needing to invent the wheel in a lot of areas. For example, in Zambia, I was on my first mission with MSF many years ago, was doing a cholera prevention campaign in the peri-urban slums of Lusaka. And when I was visiting in June, it had been almost 15 years. And I was hearing from the colleague working for Lusaka Water and Sanitation about the huge improvements in water supply and access to sanitation in these areas. And the work that was done before 2018 wasn't related to a national cholera plan. This was just good WASH programming, right? So the National Cholera Plan has the full picture, but there are already elements that are planned and ongoing within different ministries with different stakeholders doing their typical work. So that's a bit where the NCP is trying to pull all of these existing plans or programs together. So we have a bit of an overview and we can focus our efforts for future plans and programs. A good NCP should also be dynamic and operational. So again, it isn't something that's written, stamped. We pat each other on the back and throw it on the shelf. No, it's a plan that we need to come back to, something that we want to monitor, keep an eye on, and 6, 12, 18 months down the line, as we're doing these reviews, think about what's working, what isn't, what advocacy needs to take place, what needs to change, etc. So when we talk about the pillars, first and foremost is surveillance. This tells us where to intervene, and the previous webinar in this series was on the PAMI methodology, previously known as the hotspot mapping, which of course is based on the surveillance data, and we'll speak a bit more about that in a few moments. On top of the surveillance, we then have these other pillars, healthcare systems and case management, the oral cholera vaccine, which we'll hear more about in the second half of today's webinar, and WASH. And on top of this, this is deciding which of the interventions we do in those PAMIs or hotspots. Community engagement is cutting across all of these pillars. It's on top, it's integrated within, and it's really a critical part of the NCP development that we have the key community engagement stakeholders, ensuring that we don't have the top-down approaches that can look good on paper and then not be relevant for the diverse and heterogeneous communities and cultures that we work in. Tying this house together is the leadership and coordination aspect. Again, this is, in this long-term fight and for any particular outbreak, we need to make clear who's going to do what, who's going to communicate with who at national and subnational level. And that's what this pillar is all about. And this is all supporting the work towards the goal of ending cholera in the global roadmap for 2030. That's the introduction. I'm now going to dive in a bit onto the NCP development. I wonder how I'm doing on time. And I will check the WhatsApp and hope that Amy can let me know while I'm diving into this. This is the part that really I could stretch out 5 minutes. Yeah. Okay, well, let me speed up. So these are the 4 phases of the NCP, and you can see that and inception and development are the first two steps. So I think that's mostly what I'll focus on here. There are the preparatory phases, and then the work done in each of the 5 pillars. I'll put up the other text just so you can skim it. But this preparatory phase, it's ideas I've already covered. So this is the declaration of country commitment, defining leadership and coordination mechanism. And then it's what we call the situation analysis, stakeholder mapping. This can take place in different ways, in different workshops, some of it in parallel. But we have the country profile, which talks about the entire country context. It starts to get into the epidemiological history, and then we're looking at that PAMI hotspot analysis, which is another significant exercise that needs to be run within this inception phase. This feeds into the situation analysis, which is each of the pillars doing a self-assessment, doing a SWOT analysis. This feeds into those pillar-specific strategic objectives and formulating the national goal. So you can see that this inception phase has a lot within it. And it is, I think that the line between inception and development is a bit blurred. And in a lot of instances, they just run together. Then that development phase is where you really dig in. Once you have each of the 5 pillars, overall strategic objectives, you start to work on sub-objectives, on priority activities, develop those operational plans and budgets, specifically focusing on the PAMI areas or hotspots. So this is a discussion that has to happen in country, and I think we'll hear a bit from Sebastian on that, on national work versus the important subnational work. Focusing on the PAMIs will make the biggest difference. So that's a bit what the NCP, this is what countries are encouraged to do. Then the M&E framework and the submission of the plan to the IRP. Let me quickly speak about that. I'll come back to that other slide in a moment. You see the bigger picture here. Step 1, the NCP is developed and submitted to the independent review panel at the GTFCC. It's reviewed by this independent review panel. Feedback is given, potentially. Small revisions or large revisions are made, and then it's endorsed by the IRP and launched and implemented, monitored, and revisions can take place. This IRP, what are they judging NCPs on? This is a really interesting question that you asked. Let me try to summarize the primary criteria that the IRP uses to endorse an NCP. It asks whether or not the NCP was developed with the engagement and active participation of all relevant actors in this multi-sectoral approach, right? So if it's just MOH, if it's just a few consultants, if it's done correctly, check. If it's not, not good. But I think I've made clear that I don't think anyone on this call would be rushing to do non-participative approach. So that's the first and most critical, but it's not usually a very high bar because I think most countries do take this seriously. Then there is much more detailed review criteria for the situation and analysis. So this is whether the previous hotspot methodology or new PAMI methodology was done well to identify the areas for multi-sectoral interventions, whether the WASH context was reviewed well, whether the capacity assessments of each pillar were done to a large and strong enough degree, and other areas within each pillar, have they done X, have they done Y? And there is complementary guidance on some of this. Then there's a look at the operational plans on their activities and budgets, whether or not they're relevant. They link back to the capacity assessment and the overall approach. And finally, whether or not there's a strong monitoring framework defined and established. So these are the main criteria that the IRP used to review NCPs. A quick side note is that we are working on a potential revision to this process, just because, you know, imagine a country works for some months on this full NCP process, brings together stakeholders, and maybe some things are done insufficiently, incorrectly, whatever. And then the IRP comes back and says, you need to do this, you need to change that, you need to do whatever. It's a bit late in the process. These countries need to go back and do a lot of the work again, and this might lead to fatigue. It might lead to some countries just saying no and going off on their own without IRP approval, which we wouldn't suggest, but of course is their right. So we're trying to work to make this process to have quicker feedback, so that countries are able to take on some formal feedback earlier in the process. First, we're working on a means by which countries can submit some of the work done in the inception phase. There's a separate discussion on whether or not there can be some feedback on whether or not the POMIs were done correctly, which would save a lot of time if POMIs are done incorrectly and then work is done after. That would be a problem. But on the CSP side, we're looking at doing kind of review of the work done so far, right? So if you've done the POMIs and some of the situation analysis, then maybe that work can be submitted for quick feedback to help guide the stakeholders on the next steps of doing the more in-depth situation analysis, defining objectives of pillars, and then shifting to the specific multi-sectoral interventions for each hotspot or POMI. Then there's a second and related initiative on having kind of pre-submission review before submitting to the IRP, which the IRP is a much more formal and heavy process and involves a network of global experts on each of these pillars that have a limited amount of time. So it can take some time to get all of the feedback and give the feedback to countries. We're looking at a kind of a rapid feedback on draft NCPs so that countries can do some revisions before submitting to the IRP. Okay, so normally I would dive in to each of these steps in much more depth, and I will slowly go through these slides with my remaining 2 or 3 minutes here. But just to say, of course, all of these, as noted, all of these presentations are going to be shared. So you will have a chance to get these slides. And at the end of the presentation, I'll share my email and we'll mention that, of course, the CSP, we can be approached for further discussion if you're about to launch or looking to launch the NCP process in your country. We're available for remote support and potentially in-country support. Let me just do the lightning round here. We'll go through the inception and development phases. I've mentioned the declaration of country commitment. This is really the first and most important step. Then defining that leadership and coordination mechanism is critical, and then allows the identification of the pillars, the pillar leads, which naturally leads to the mapping of stakeholders to ensure that everybody that needs to be included in the NCP process can be included. Then these pillars work on the country profile, on the relevant geographic, demographic, socio-cultural aspects to consider. Then we jump into the POMI process, which was outlined in that previous webinar. There's new guidance that was released in April this year and even just in the past couple of weeks. Then, based on that, situation analysis is undertaken. As I've mentioned, this is done by each pillar. The status quo, what's working, what isn't, a SWOT analysis, looking at gaps and capacities to move forward. The national goal is formulated, whether or not this is cholera elimination or cholera control by what year. And then we look at the pillar-specific strategic objectives. Then we're ready to move into the development phase. I think I'm repeating myself, but it's always good to repeat yourself. Maybe this will sink in a bit. As a formerly student that didn't always pay attention, it always helped me to have things repeated. So here's a bit of the workflow in horizontal fashion, deciding to develop your NCP, setting up your working groups, carrying this out. Then you can see the country profile, PAMI's situation analysis, and then it moves into that development phase that I mentioned. Once all of this is done, you can then work on the activities, the budgets, M&E, and then submit to the independent review panel, or as mentioned, this step is under discussion with the GTFCC steering committee to hopefully have a better, more rapid and more supporting step here. I won't go into detail on the implementation. Of course, this is the critical aspect of the NCP, and for different pillars, this means different things. But also the monitoring and reporting is really important. This needs to take place every year for some indicators, the GTFCC standard indicators. Obviously, there's epidemiological reporting that needs to take place. And then the country defines its own national monitoring plan for its NCP. Voila. This is the end of my formal presentation. I think I was just a little bit over time. And now I will hand over to Mr. Sebastian Yenin from the Nigerian Centers for Disease Control for his presentation on Nigeria's NCP development. Thank you. Sebastian, over to you.
Thank you, Emmett. This is Sebastian Yenan. I am the Director's Subnational Support Department and also the TWG lead for cholera here in Nigeria. So I'm going to give you an overview of how we have been developing the NCP here in Nigeria since the coming of the CSP. Next slide, please. Nigeria, as most of you are aware, is a country with over 200 million population. It has a three-tier system of administration, the federal, the states, and the local government structures. There are presently 36 states in Nigeria and the Federal Capital Territory. And we have 774 local governments here in Nigeria. Cholera is actually not new to Nigeria. The country is actually endemic for cholera since the early 70s. Mostly in the earlier days, cholera was being reported in the southern part of the country. But there is a shift now to the northern states where we are actually having ongoing outbreaks. We have had intermittent outbreaks over the years since the 70s, but the major one was actually the one in 2021, where Nigeria led globally with a total of 111,062 suspected cases, including 3,604 deaths from 36 states and the Federal Capital Territory. Presently, we are still having cholera outbreaks. Between January and September this year, we have already recorded 3,267 cases with over 100 deaths due to cholera. Next slide. Next slide. This presentation, the previous slide, please. The previous slide. This presentation is actually going to focus mostly on activities that were conducted in collaboration with the country support platform. Before then, Nigeria actually committed to the ending cholera roadmap by 2030 in the 71st World Health Assembly held in May 2018. Immediately after this meeting, the then Director General of NCDC, Dr. Ikwehe Kwazi, saw the need to actually start engagement with key stakeholders in the watch sectors, immunization sectors also, the sister agency, National Primary Care Development Agency, to make sure that we have a national cholera plan in line with the GTFCC existing guideline that time. So sessions actually kickstarted by having advocacy visits to these key line ministry, department, and agencies and development partners existing in Nigeria. But I would like you to actually know that before the commitment to the ending roadmap strategy, we already had an existing cholera technical working group, multi-sectoral, where key stakeholders align strictly to whether they are in the health sector or in the watch, coming together with focus on how we will control cholera in Nigeria. So activities actually started as far back as 2017 with the creation of a cholera technical working group, domiciled here at the Nigerian Center for Disease Control, headed by an incident manager. Well, looking into the expected strategy that the GTFCC actually expect countries to address, our plan is actually to reduce annual incidence of cholera to 0 by 100,000 population, to also reduce the number of deaths by 90% by 2027, and to reduce the case fatality in line with the global roadmap to less than 1% by 2027. Immediately in that 2018, we went into the development of cholera hotspots map supported by the GTFCC and the WHO colleagues here in the country, who we were able to develop a 2018 to 2022 national cholera plan, which was submitted to the GTFCC. And that plan actually supported the country to access the global stockpile of vaccines in our preventive and reactive campaigns during outbreaks between 2018 to 2022. Next slide. Now, by 2022, the country was privileged to actually have the country support platform assigned to Nigeria. Now, the coming of the NCP, the CSP identified the needs to actually look into the leadership and coordination structure of Nigerian efforts towards controlling cholera. Like I told you earlier, what we had then was a technical working group domiciled here at the NCDC with colleagues from different line ministries and development partners. And the highest level of authority then was the Director General of the Nigerian Center for Disease Control. The CSP saw the need to actually look into this leadership structure, vis-a-vis the fact that Nigeria actually has a separate public health institute, which is the NCDC, that has responsibility for disease detection, prevention, and response, different from the Federal Ministry of Health that has also other activities and authorities along policy formulation and funding of available work plans. In that respect, the country was able to look into the issue of this leadership, existing leadership and coordination. In the last World Health Assembly in 2022, the Honorable Minister of Health committed to actually increasing the level of leadership and coordination to the Office of the Vice President of Nigeria. So what we have now in the present draft of the NCP is to have the chairman of the steering committee for the control of cholera in Nigeria as the Vice President, Federal Republic of Nigeria. Then the co-chairs are the Federal Ministry of Health Minister, the Federal Minister of Water Resources and Sanitation Minister as co-chairman. Then the Director General of the NCDC is the Secretariat. We look at the GTFCC guidelines and decided to actually have a review of how the thematic areas will be used to control cholera in Nigeria. You can see what I have here. This is what we are working with now, leadership and coordination as pillar, surveillance and epidemiology, laboratory, case management, which actually replaced, which actually is the replica of the healthcare system in the GTFCC guideline. Then we have the risk communication and community engagement pillar, water, sanitation, and hygiene. And we added solid waste management also to complement the WASH. The existing OCV pillar, the OCV then in 2018 was joined with logistics. Then we also introduced a research pillar. So we are working towards controlling cholera in Nigeria with actually 9 pillars in the existing NCP. Next. Like I told you earlier, immediately after the 71st World Health Assembly meeting in May 2018, the commitment actually started in Nigeria. However, by 2019, there was a review of the guideline for the development of NCPs by the GTFCC. And it was this guideline now that actually supported the ongoing effort now with the country support platform to attune what we have for onward submission to the GTFCC. We kickstarted the process again by developing another cholera hotspot map using the existing guideline in the GTFCC. Quantitative approach was conducted for the initial identification and prioritization of hotspots using the mean annual incidence and the persistence over a 5-year period. So this was also the same process we did earlier in 2018. So there was a repeat of the hotspot mapping also in September 2021, which is supporting what we are doing now. So 2017 to 2021 data were retrospectively desktop reviewed in the NCDC to make sure that key stakeholders really key into what the GTFCC guideline provided. Qualitative approach was also conducted via a series of meetings and validation workshops to make sure that the hotspots identified actually are what is obtainable in the country. So based on these identified hotspots, we went into reviewing the existing 2018 to 2022 Nigerian cholera plan. Next step. Next. The 2021 cholera hotspots in Nigeria came up with a total of 126 hotspots and from 126 hotspot local government from 22 states, representing 41 million population, which is approximately 18% of the total population of Nigeria. So what you can see here are states that are either high regular states or high epidemic prone disease states, medium, low states that are having cholera. And the 22 states now, densely populated now, mostly in the northern part of the country. Adamawa State currently having outbreaks, Borno State having outbreaks, Katsina, Kano, Kaduna, Zamfara State. We are presently having ongoing outbreaks in these states, and like you already know, it's either they are high regular cholera endemic states or local governments, or high epidemic prone cholera hotspot states and local government. Next. So with the coming of the country support platform, we had a first kickoff meeting with the new DG of the NCDC, Dr. Ifedayo Adetifa, who chairs that workshop to actually review the existing 2018 to 2022 National Strategic Plan of Action for Cholera Control. So this is what we call our document in Nigeria, National Strategic plan of action for cholera control in line with the new GTFCC template. Key stakeholders actually, as earlier already identified, that have been working with the country since 2017, from the line ministries of Federal Ministry of Water Resources, Federal Ministry of Environment, the National Emergency Management Agency, the National Primary Care Development Agency. Key stakeholders in the development sectors were also part of this workshop. And this is actually the picture from what transpired, and the DG of NCDCs, they are centered, who has been supporting the ongoing effort to make sure that Nigeria is able to make this submission to the GTFCC. Next. So after that series of meetings, pillar level, depending on what are the action points that came up from the first meeting, were assigned to the respective pillars already identified, be it coordination, surveillance, laboratory watch, risk communication and community engagement, vaccination. Everybody went to see that they continue to address the gaps, the action points that were actually identified before this meeting. So by the time we had the second technical review meeting, we will assemble precisely in August 2022 to look at the issue of prioritizing activities, defining national goals, and also coming up with the defined monitoring and evaluation framework in line with the GTFCC. Luckily, there are also indicators by the GTFCC that we also had existing indicators that guide the eventual M&E framework that the country is going to have in the NCP. Next. Now, just like the previous first and second workshops, action points actually were identified. Pillars went into site meetings over the period since the validation, since the second meetings onwards towards the validation workshop. Now, the validation workshop brought key national and subnational stakeholders to review the document. Like I told you earlier, the country has 36 states plus the Federal Capital Territory and also 774 local governments. So in the validation workshop, we make sure that we brought key stakeholders from the states, from the local government. Either you are representing WASH, surveillance, risk communication and community engagement, laboratory, you are an IM in the state, you are representing coordination. They were all assembled respectively in areas that we know are actually cholera hotspot states to this validation workshop. It was also chaired by the Director General NCDC. You can see him there, Dr. Ifedayo Adetifa. Then we had colleagues from the CSP headquarters. Emmett is there, Catherine. Before then, we had Dr. Ebel Augustino, who was the first CSP manager in Nigeria. So this validation workshop was conducted earlier this year in June 2023. Well, and since then, we were looking at how to finalize this document and submit to the GTFCC. So what was actually the objective of this validation workshop? It was to validate the format and broad content of the drafted National Cholera Plan 2023 to 2027, including looking at the background, the hotspot, the situation analysis, the implementation plan that each pillar intends to carry out their activity. Then we also look at the issue of validating the indicating clear goals, objectives, activities, and milestones that need to be attained. Well, there was also an aspect of the budgeting, which this validation workshop was able to come up with. Next. Now, what are the lessons learned from what we have done so far? Is to actually identify that cholera, unlike in the past, where it was health sector driven, the need for the development of national cholera plan actually brought the need for synergy between WASH and health and WASH and health sector actors together, whether you are in country as a ministry, department, or agency, or you are a development partner, or civil society, the media, to see the need that there must be one cholera response plan in the country. And that is what has driven what we have been able to actually achieve so far, that we are going to be submitting a document where there is a multi-sectoral participation in the development of this document, including development partners in Nigeria. The 36 states,
Sebastian, if
774.
you can wind up, please.
The 36 states, 774 local governments in Nigeria actually participated in the development of this document, and we are hopeful that the next phase of this document conclusion is to get it transmitted to the GTFCC. Thank you.
Thank you very much, Sebastian, for that very good presentation on the Nigerian part, and I can see there is a lot of progress that has been made, and I've seen quite a number of questions in the Q&A. Please, colleagues, let's learn and see what Nigeria has done and a few other countries, and we can learn a lot. And this is the standard that we want to follow, all of us. So thank you very much, Yenan. Thank you, Emmett, and also thank you, Dr. Abhishek. At this point in time, we'll ask quickly, Emmett, we're giving you very few minutes to just give us the process because we are running short of.
Yes, this is also the Q&A time, yeah? How many minutes do we have for Q&A? Is it 10 minutes from now?
So proceed. We have less than 10 minutes, actually.
Okay. Well, then let me mention two things, and then I'll come back to this slide to ask Sebastian, or we can maybe better that we take questions from the group. So just to wrap up on the CSP side, as Abhishek outlined, the country support platform is here to support countries that are interested in developing a national cholera plan. He mentioned that we have program managers in 5 priority countries right now. It is not the plan that we expand to have program managers in all countries. So going forward, we're going to look at continuing to address and work towards these outcomes, but through other means. So using the PRIAMs, Abhishek himself will hopefully start supporting Nepal. We're in discussions with Cameroon to have support from our colleague in DRC. So I mentioned here that, of course, there are some tools, templates, and guidance. We're very open to carrying out remote support, so walking countries and relevant stakeholders through the process in more depth. In longer webinars focused on your countries, there can be, having said that, there can still be potential visits by CSP program managers or global team members to help organize and facilitate workshops. There can still be potential deployments of further technical assistance from our team, from the GTFCC, working groups, etc. So don't hesitate. You see my email down below. Once again, this presentation will be shared, so you can take it once you get it there. Reach out to me directly, and we will discuss within the team, and discuss with you what the needs are and how we can best support you. So with that, I put these questions up that I was going to ask Sebastian, but seeing that we don't have much time, maybe we can take any questions that are still in the chat. I had responded directly to a few of the questions, but I don't know, Dr. Fred, do you see any outstanding questions? Or is there some other way we could have colleagues ask us directly here?
Yes, Emmett, very important. We will have just 5 minutes for some live questions, especially, like I said, colleagues that are using Portuguese. This is the chance to ask. There is a question that is in the chat regarding how long does it take for the IRP to review the document, the NCP draft once sent. I think that's the only one which has not been responded to. Most of them have been responded to, but we can now allow members to ask. So please indicate by raising your hand quickly. We only have 5 minutes before we move on to OCV. So I see that there are no hands. Probably the only question is the same one. And also, Emmett, maybe if you can emphasize the difference between the NCP and the response plan, because I could see one or two people still asking that they have some of these response plans. What is the difference? Are we duplicating and stuff like that? Probably you can attend to that. Thank you.
Excuse me, Kapaya.
Please go ahead. Go ahead. Thank you.
Yes, please, without much ado, I will just try to give a little answer to the second question, which is very important, and most likely the third from Emmett. The challenge we actually had in developing the NCP in Nigeria is the fact that the coordination is actually not one. We have a national institute, which is the NCDC, separate from the Federal Ministry of Health. Then the immunization aspect of it is in a different agency, National Primary Care Development Agency. The watch sector is also played by the Federal Ministry of Water Resources, Federal Ministry of Environment. So it was actually very difficult to link most of the resources available, both human and materials, guidelines, policies that will drive the development of this NCP. So this was one of the major challenges. And also, like I earlier said, different ministers, different chief executives run these agencies, ministry and department. And that was why it was actually very important when the CSP suggested the need to raise the leadership and coordination of Nigeria to a higher level beyond the minister. And the country actually obliged. And we're now working towards having the Vice President of Nigeria being the chair of the steering committee. My advice actually to other countries is to actually identify who are the critical stakeholders that will drive the development of an NCP, get them early identified, then try to assemble available resources before you kickstart the process. Thank you.
So thank you very much, Emmett.
Yeah, no, I think that's exactly right. And yeah, again, I presented the theory, and Sebastian is speaking practice and from experience, right? So yeah, getting that the highest level buy-in is possible, is critical. And once again, that perhaps as the CSP discusses with countries that are interested to launch, that's one area that we can potentially help, is on that advocacy and those conversations with stakeholders to ensure that, you know, at the first step of inception, to get that highest political commitment will make everybody's lives much easier throughout the rest of the process. So if you're looking to start your NCP process, we're happy to even engage at that level. Yeah, and to respond, Dr. Fred, to that question on response plan versus National Cholera Control or Elimination Plan, it's true, they're different things, right? If you have an outbreak, you're shifting into a very different gear. You're working, you know, day and night to save lives. But and that's an elimination. I mean, that's you work on your response plan, and you work with all stakeholders, and you work flat out for those months that the outbreak lasts. And I'm not trying to take away from any emergency outbreak response plan. The concept here is the National Cholera Plan should be above, and, you know, should be inclusive of and above any acute response plan, right? So again, you don't, in the middle of an outbreak, you don't stop and divert resources away from an outbreak to start this national cholera plan work. In principle, the best case scenario is that it's done at a more stable time, and this is the critical point, that it acts kind of as the umbrella for the long-term plan and any future outbreaks, right? So it should be the full plan for your control or elimination over several years, but there may be an outbreak after 6 months, after 18 months, and aspects of this plan should already have been thought through so that you don't start from scratch, right? You already have these coordination mechanisms in place for the different pillars. You know where the hotspots are. People have already been having these discussions, and your response can then happen very quickly. You probably need to develop an acute response plan underneath the cholera control or elimination plan. But yes, they're separate but related. I hope that was a clarifying answer. Over.
Thank you very much, Emmett, for that very important answer to the question. And colleagues, thank you very much for your attention. Now we are moving on to the next session, where we are now going to talk about OCV. And I saw that there were a lot of questions in the chat. There were a number of questions in the chat on OCV, and we didn't want to attempt to answer because we knew we were going to have this. So I'm now handing over to Rina, who is going to take us through the first part of the OCV. Then thereafter, Malika will take it up. Rina, your turn. Thank you.
Great. Thank you so much. Next slide. So hopefully some of the questions that you have that you've put into the chat and the Q&A will be answered with this presentation, but if not, we're happy to discuss after. So we're going to talk today about an introduction to OCV, the use of OCV in emergencies, and also the preventative use of OCV, and then OCV and the multi-year plan of actions, including OCV prioritization, development of the multi-year plan of actions, and submission to Gavi. Next slide. So just wanted to re-emphasize this, won't spend too much time on it, but just these are the key elements of the global roadmap, which includes oral cholera vaccine. Next slide. So as has been discussed in previous sessions, there are 5 pillars that form the basis of prevention and control of cholera. And the use of oral cholera vaccine, or OCV, is one of these pillars. And it's integrated with activities such as community engagement. Next slide. So what are the WHO recommendations on OCV? So WHO recommends OCV use in cholera endemic settings during outbreaks and high-risk humanitarian crisis. Always in conjunction with other cholera prevention and control strategies, so really never alone. Vaccination cannot disrupt the provision of other high priority health interventions to control or prevent cholera, so this includes WASH. So for the current vaccines, which we'll go over in a minute, 2 doses should be given a minimum of 14 days apart to individuals greater than 1 year. And for emergency settings, this has changed a little bit, which we'll talk about in a second. Where the risk of cholera infection is continuous, revaccination is actually recommended after 3 years. And a single dose strategy using the same vaccines could be considered in areas experiencing cholera outbreaks. So a 1-dose strategy has been used recently as for reactive vaccination. And pregnant and lactating women should always be included in OCV campaigns. There's a high benefit and really minimal risk. And there's some resources on this slide which you'll have access to. Next slide. So, brief introduction to the vaccines. They've been around for quite a long time, since 1991, but more recently, 2 oral cholera vaccine products were WHO pre-qualified in 2011 and 2017. So these oral vaccines were considered game changers in cholera prevention. You know, they're affordable, they're easy to use, no injection supplies, and they've been demonstrated to stop or prevent outbreaks. So OCV really can have these short or medium-term impacts by boosting immunity right after, by boosting immunity during outbreak and reducing that burden. But again, I just want to reiterate, as I said before, that it's important to use this in conjunction with other cholera prevention and control strategies. And really just provides this window to implement longer-term cholera control activities with WASH and community engagement focus, as I mentioned before. Next slide. So the global OCV stockpile was created in 2013. The stockpile is supported by Gavi, the Vaccine Alliance. The International Coordinating Group on Vaccine Provision oversees the management of the global stockpile of all emergency vaccines. So there's members from WHO, UNICEF, IFRC, and MSF. The global OCV supply is currently strained until at least 2025. What does that mean? Well, ICG has temporarily shifted from the 2-dose OCV campaign strategy to support 1-dose reactive campaigns until the supply increases, and this happened in October of last year. Next slide. So there are 2 vaccines available in the stockpile. They're essentially the same, targeting the same serotypes. The cost is a bit different. They can be stored for 24 months or to 30 months at 2 to 8 degrees. And the target age group is everyone greater than 1 year, including pregnant women and immunocompromised persons. Administration, as I've already mentioned, is oral. You drink all the contents. And really no serious adverse events have been reported in more than 25 million doses that have used globally. Very, very rare minor adverse events occur, such as vomiting or gastro discomfort. Next slide. So how does OCV compare to other vaccines in terms of cold chain requirements? I think this is a really interesting thing to note. So the presentation is 5 plastic tubes per strip. You know, PCV is a glass vial and Penta is a glass vial. And you can see the difference in the cold chain volume. OCV is a little bit higher. So it does take up more space than multi-dose glass vials. So countries do have to ensure that they have sufficient cold chain capacity prior to conducting the campaign. Next slide. So I know there was a question about OCV effectiveness and durability. So we have the 2-dose administration. The effectiveness is estimated to be 76%. Although 58% efficacy from randomized control trials. So the protection is up to 3 years. The 1-dose administration, a systematic review is in progress. So more information will be forthcoming on that. Note that OCV is less effective in children less than 5 years of age. Next slide. So I wanted to talk about the different scenarios for the use of OCV. So we first have, well, let me actually start on the other half of the slide in the emergency setting. So humanitarian crisis due to man-made or natural disaster. So that would be preemptive vaccination. The target populations might be refugees, IDPs in camps and host communities. And the vaccine source would be the ICG stockpile. Now, I know there was a question in the chat specifically relating to Chad, and this may be a scenario. So then reactive vaccination when there's an active outbreak. So we're targeting residents in areas at risk of spread or outbreak. So the vaccine source would be the ICG stockpile. And there have been few cases to date, you know, in targeted areas, but cholera. So I should start over with that. Circumstances or conditions most appropriate for vaccination. Few cases in targeted areas, but maybe there's a risk of spread. That might be an area targeted for vaccination. Next slide. So OCV vaccination strategies, just like other vaccination campaigns, we have fixed sites, we have mobile sites, we can have door-to-door vaccination. It is oral, so there are many ways to do it depending on country capacity and what makes sense for those target areas. Next slide. So now I just wanted to share with you the number of approved requests and countries per year of validation before I hand it over to Malika. So as you can see, the number of countries with outbreaks is increasing and the number of approved requests is also increasing. So supply is increasing. Next slide. And here I will hand it over to Malika.
Thanks, Rina. Good morning, bonjour to everyone. So I will be presenting the use, before I present the access to the use of the vaccine, whether it's for emergencies or preventive requests. I'd like to present the situation of the stockpile and the use. So the demand for OCV has been increasing all over the year, as well as the number of vaccines available. This graph shows the proportion of use and shipment through preventive and through reactive. So as you can see in the graph, the majority of doses that are used are for reactive use. And this is also linked to the fact that for the moment, as presented by Rina, the stockpile is constrained, and for the moment, only doses for reactive campaigns are provided. So since 2013, the creation of the stockpile to 2021, 40% of the doses were used for preventive. We are facing larger outbreaks, so this implies more reactive, and this leave less spaces and less doses for preventive. And because there is less preventive campaigns, this leads to more outbreaks. So we wanted to highlight that. There is insufficient availability of doses, although the producers are trying to increase the production. Next. So in this, you see the number of shipment countries. Since the creation of the stockpile, it's more than 160 million doses that were shipped, and in total in 27 countries that have used the OCV. And we can see that the biggest shipments were provided to DR Congo, Ethiopia, and Nigeria. Next. So this is the 10 years of the creation of the stockpile. As I mentioned, since 2013, over 161 million doses were shipped to 27 countries, and you can see those countries in the map that have been used OCV, whether it's for preventive or for reactive use. Over. We wanted to highlight the increasing gap in terms of OCV. As you can see, the number of shipments of doses has been increasing all over the year. So in green on the bottom of the graph, you can see the number of doses shipped. However, we want that to be reflected according to the potential demand, the real demand that we have. And for example, in 2022, we shipped 31 million doses. There was an availability of this quantity. It's moving. Can you go? Someone has, yes, again, thank you. And for example, this year it's over 24 million doses that were shipped. However, we are providing 1 dose out of 2 because of the supply constraint. And if you see in 2023, for example, the real somehow the real need for vaccine, if we include the second doses that were not provided, the area that were not approved because of the constraint doses that we really need to focus on the most limited area. In total, it's more than 78 million doses that would have been needed also, but we shipped around 24 million. So the demand is exceeding the availability of the doses. Next. So what's the situation for the stockpile into this year and the campaigns? As of today, we are responding only to emergency requests through the ICG mechanism that I will develop later. So we received requests by 12 countries. 10 were approved and 11 partially approved. Only 1 was rejected. The requests that we received are somehow pre-reduced because of the shortage. We know that countries are asking and demanding the minimum of doses that they can, and are trying to really narrow the requests. In total, the availability of doses for this year was 37 million, and we already have shipped, as of October, 28 million of this availability of doses. The number of doses requested is 62 million doses, and we estimate the gap of the need of the vaccine for this year to be 70 million doses were really needed, and we know that this number is already somehow underestimated. Regarding preventive vaccination, since this year, all the requests have to go through Gavi, but before that, we had approved 3 requests for preventive use, and this represented 17 million of doses. However, because of the need, the outbreaks that are occurring in so many countries, and the availability of doses that we cannot ship those doses to preventive for preventive use. Next. In this map, you can see the number of countries that reported cholera cases, that are over 28, and the countries that implemented campaigns. So it's only reactive. So in total, 11 countries implemented campaigns, and you can see in this map, it shows the number of doses that were used, and for example, 7.7 million doses were shipped as of today this year to Ethiopia. So now that I presented the situation in terms of stockpile and the number of doses used in the world since the creation of the stockpile, I'd like to show how how countries can access to the stockpile, whether it's for emergency use or for preventive. And we'll start by the emergencies. Next. So Rina presented the three situations for using OCV. So it can be for preventive, so it's planned campaign for 3 to 5 years, or for emergency situation that can be for reactive in case there is an outbreak, or for preemptive in the situation of humanitarian crisis. So we will be seeing the emergency ones. Next. Okay, so you can have access to the doses, and vaccination should not disrupt the provision of other high priority health intervention. So it should be always coordinated with other prevention measures as WASH activities. The target areas and population should be clearly identified in each request, and an assessment of the current and historical epidemiological situation should very well be described in the request. The vaccination should cover as many eligible people as possible and as quickly as possible. And yeah, next. So for the emergency use, the request has to be submitted to the International Coordination Group Secretariat. The request is presented in two forms, one Word document that you have to fill and one Excel sheet that provide the EP information, the history of previous outbreak cholera, laboratory information, and estimate of the vaccine. I want just here to highlight that this document has been improved by Mr. Vincent Mondibourg, who works with me. And this tool is now easier to see the EP curve. It has a dashboard that allows to have a better view of the outbreak situation. So with those two annexes, the vaccination plan has to be submitted, the map areas of the vaccinated targeted places, and as well as the budget with the Gavi budget template has to be provided. The decision should be taken less than 72 hours, and we will see all the process. Next. So what are the minimum requirements for a request? First, there should be laboratory confirmed. The request should present the current and the historical epidemiological cholera situation with a good description of person, place, time situation of cholera. I really invite the countries that can face outbreaks to already collect those information to have in advance something prepared in case of a potential submission. The request should also present the risk of extension. What is if there is a risk of extension in context of humanitarian or WASH condition or anything. The vaccination plan and strategy should be described and provided. And the description of the case management, the infrastructure, whether there is ORP, or what are the capacity that is in terms of health management that is already put in place. There should not be a campaign that has been implemented in the 2 previous years, and that's why we asked the historic of the campaigns in the previous years. And of course, this has to be reviewed and agreed by the national health authorities. Next. So what is happening behind the scene when countries submit a request, and what is the delay? So a country will submit a request to the ICG Secretariat, and the ICG Secretariat will be circulating to the ICG member within 24 hours, will be submitting the request. The ICG Secretariat is members is composed of 4 entities, IFRC, MSF, UNICEF, and WHO, who will be reviewing the request. If there is no questions or additional information that are requested, the ICG will approve and provide or reject the decision within 48 hours. If it's not the case, the ICG might request to the country additional information. And this is happening quite a lot of times, that the ICG members request additional informations or ask some clarification through calls with the countries to get those information. When it's approved, the ICG, the UNICEF SD will do a procurement to the manufacturers, and the dose will be shipped to the country. So all this process, from the submission to the shipment of the doses, should take ideally 10 days. Next. So this in this slide, we wanted to show the key indicators from the ICG. So in total, from the submission to the confirmation of the outbreak should be 7 days. From the decision, from the submission, the ICG should take and provide the decision within 3 days, and the doses should be delivered in 7 days, and the campaign has to be implemented 10 days after the reception of the doses. So in total, from the submission to the campaign, all of this should not be exceeding 27 days, but we will see later that this is not the case. For example, we have a median of 55 days for the first indicators from the submission of the time of the submission and the confirmation of the outbreak, and a median day of around 90 days for the delivery of the doses. Next. Yeah, next. Those graphs, you can see them in the dashboard of the OCV dashboard. And they show over the time the indicators. On the left one, it shows over the time since the creation, since 2016, sorry, the time between the request and the shipment. As I mentioned, it should be 10 days, is the key indicator of ICG. However, for this year, we have a median day of 19 days. And on the right, this is the distribution between the shipment and the first round. And for a key indicator of 10 days, we have a median time of around 15 days. And I'd like here to highlight that this is really difficult. We have too many campaigns that are implemented very late after the declaration of the outbreak or the submission. The reason can be different. It can be a reason of budget. Sometimes we don't know why, but it's the time to implement and to be prepared. So it's very important, as soon as there is an outbreak that is declared, to be prepared and to do the maximum to implement the campaign as fast as possible. If the campaign is implemented too late, the impact will be, of course, lower. So I really wanted to highlight the need of implementing the campaign as fast as possible to avoid a spread of the outbreak. Next. So that was for the emergency use, and we will see now the access to the preventive vaccination. Next. So we already showed this slide. So for the preventive, it will target the people living in the PAMIs. There will be the request will go through Gavi. In the past, it used to be through the GTFCC Secretariat, but since this year, it's through Gavi, and many documents have to be filled. Next. So what is required for submitting a preventive request? So first of all, the first step would be to have the PAMIs that are identified by the country. If there's not this identification, this is not possible to have a multi-year plan of actions. So there should be a report of the identified PAMIs, a document of the multi-year plan of action. In terms of NCP that was presented by Emmet before, for the moment, it's not mandatory, but it will be required systematically soon. And there should be a commitment to go beyond vaccination and to develop long-term prevention and control measures. Yeah, next. So my colleague Morgan Dominguez has presented in a former webinar how to identify the priority areas for multi-sectorial interventions, which represent the most affected areas in the recent years. So this exercise is done, as I say, is the first part that has to be done by a country. We will not be supporting countries in developing multi-year plan of actions if this first step is not done. So how is identified PAMIs? It's through 4 epidemiological indicators: the incidence, the mortality, the persistence, and the test positivity indicators. I will not go through that, but it's just to give you an idea of the epidemiological indicators. While the PAMIs are identified, the GTFCC Secretariat developed also a tool to prioritize among those PAMIs which one will be vaccinated first. Because of the constraint on the stockpile and because some other criteria has to be included for OCV, the GTFCC Secretariat has been developing a tool. So after the PAMIs are identified, they should be prioritized for 2 doses campaigns. I will, yeah. Next, sorry. So this shows only how to prioritize for OCV, what we take into account. So this is first, we need a data collection of the epidemiological data of OCV campaigns history and vulnerability factor. There should be the PAMI score that are already ready. And we will take into account risk score and susceptibility score. Another area that will be taken into account is the operations part, in order to know the number of required doses. Other consideration can be taken into account: the accessibility, the security, and probably a regional approach. I just give an example, but for some reason, sometimes a regional approach can be implemented, and therefore some PAMIs will be prioritized before others. So in this tool that is in development yet and that is piloted, we developed the tools that help at the end to give us an idea of the number of doses and what are the PAMIs that are prioritized for the next coming years. Next. So this gives the final result of what the tool is supposed to provide. And at the end, so it's an Excel sheet documents. This will be provide the number of PAMIs that will be targeted for vaccinations each year from the next 5 coming years. So in total, for example, for a country, from now to 2027, 100 PAMIs have been prioritized, 10 PAMIs for this year, and this represents around 29 million doses for this year. So this will allow will allow the countries to know exactly the number of doses that will be needed each year and to better plan the campaigns. So this will be an important part of the multi-year plan of action, and all the plan will be defined on this prioritization. Next. So why do we need a multi-year plan of action? What is it? The multi-year plan of action is a document that countries will need to prepare to apply to Gavi. This is the most important document, I would say. The purpose is to provide details on why and how the vaccination will be carried out in the PAMIs. So the PAMIs should be identified. This should include plans for the next 3-5 years and correspond and really match with the OCB objective outlined in the National Cholera Plan. Next. So the benefits is to better plan campaigns and not to respond only to outbreaks, but really to have for the 5 coming years a detailed plan of the campaign, and to have only one application and not multiple applications. Next. So the benefits of the multi-year plan is to have a longer time between request and implementation. If we know from now to the 5 coming years, it will allow the countries to prepare the campaigns, but also for the manufacturers to know exactly what will be the demand for the next 5 years for each country. And this will really help to have a healthier market for the vaccine, because as of today, this is not developed from all countries, and we don't have a visibility of what will be the future needs in terms of vaccines from the countries. Next. So how is it? You can see on the site of Gavi, it's available in French and in English, the version of the multi-year plan of actions. So the different parts, as I mentioned, there should be a situational analysis, the prioritization to show how the PAMIs were prioritized, what are the needs in terms of vaccine for the next years, which PAMIs will be vaccinated. A work plan outlining the activities has to be also described in the plan for each year, for each PAMIs that is developed. How will the campaign will be implemented? Will it be door-to-door strategy? What will be the other activities that will be integrated? Really the detailed explanation of the campaign. Also to provide some lessons learned from previous campaigns that were implemented in the past. And of course, with that, the budget should be also already prepared and developed. Next. So how does it look like? When the PAMIs are identified, when they are prioritized, when the multi-year plan of action is developed, and on the same time, ideally, there is a national cholera plan, the country can be ready for submitting the application. So there are 3 windows per year for submitting, 4, sorry, windows per year for implementing to Gavi, generally 1 in January, in April, July, and October. So for the submitting, the multi-year plan of action should be ready, the PAMIs report, potentially the national cholera plan, the reports from other campaigns. There should be an ITAG recommendation, an ICC approval, and of course the endorsement from Ministry of Health and Ministry of Finance. Next. So this shows the process after the submission. So in blue is all the development of the submission, and you can get support from GTFCC, from my colleagues from CSP who were supporting countries in developing and multi-year plans of action, but also on supporting all the steps until the submission to Gavi. So all this part in blue with all the documents that I just mentioned. After that, there is a process at Gavi with an independent review committee that review the request and give the approval. When there's the approval, the country already has to work on the campaign, and we are on the implementation of the campaigns, but also the monitoring and evaluation of the campaigns. And all this process is requiring time between the first identification of the PAMIs to the campaign implementation, monitoring and evaluation is a long process. Next. So I will not go deeply into budget, but you know that the budget also has to submit next to Gavi through Gavi website. I will not go into detail, but just wanted to highlight also that this is a big part of the request that take time. Next. And you can have all the information on the OCV use for preventive, reactive, time implementation in following this link. And I will stop here. This is the end of my presentation, and happy to answer questions, whether it's in the chat or orally. Thank you.
Thank you very much, Malika. Thank you, Rina, for the very good presentation on OCV. And our colleagues, all of us, I think we've heard. So this is an opportunity to ask those questions that we've been asking. I've already seen a number of them in the chat, and I think that some of them have been responded to. But probably I may just ask you, Malika, one of the questions that is coming out in the chat is probably an explanation, difficult, but why has Shanko decided to stop production of the OCV at a time when we need the vaccine even more? There's also another question regarding revaccination. The question is, could you help clarify the point on revaccination with recent campaigns happening less than 3 years in an event of an outbreak requiring emergency OCV in the same area that probably had received some vaccines? So there is that question. So probably maybe you can attend to that. And I also would like to give chance to anyone who has a question, especially the Portuguese speaking, if you can ask those questions. Yeah.
Okay, thank you, Fred. So for the first question, it's the manufacturer decided to leave the market. For the moment, we are not in a healthy market. We don't have a visibility for the next coming years of how will be the demand. We know that the demand is high and will stay high, but we really need to have more visibility on that. And that's why I invite all the countries to develop and to start developing multi-year plans of action, because without that, the producer will not have the security to produce the doses. That's how it works. Although the producer have been increasing all over the year the campaign, for the moment we are using those doses only to respond to outbreaks. Because that's the availability, and we really need, in order to ensure that producers can be producing, to have all the plans from each countries of the need vaccine for the coming year. So this is really important that all countries, I think, start to plan the campaigns. For the second questions about the revaccination, for the moment, we know that the vaccine, although there's a lot of studies that are going on and we are reviewing the effectiveness of the vaccine and the time protection of the vaccine, for the moment, we evaluate the protection to be, and the duration of the protection to be 3 years. However, for revaccination, we know that there are a lot of places where there is movement of population and that need to be revaccinated. So this is something that have to be justified and showed whether a place needs to be needs vaccine, whether it has been vaccinated in the past. We know that in some context, and because also sometimes the coverage of the campaign was not reaching 85%, potential revaccination could be needed. So justification should be needed regarding that.
Thank you very much, Malika, for those answers. And I think it also answers one of the questions which is in the Q&A, which talks about what strategies are currently put in place to increase production and availability of OCV in the stockpile to meet the increasing demand. So I think one of the things that has come out is all of us, all the countries, to ensure that we develop the multi-year operational plan for OCV, because this is the only way that the producer or the company that producing can actually look at this and see the demand that is there. So all countries are actually encouraged to ensure that we have these multi-year plans. Very, very important. Is there anyone with a burning question? You can indicate by raising your hand. Anyone with a burning question? Okay, I'm not seeing any hands raised. Okay, so first and foremost, just to thank you, Malika, for this very good presentation. I'm sure countries will be reaching out for support. I think some of the things that have been there are issues of the delays in the approval process, especially for reactive campaigns, where sometimes the vaccine that countries have requested are coming at a point when the outbreak in that specific area is almost over. So there are questions like, what is the value of the OCV when actually the outbreak is almost over, when actually the purpose is to try and contain the outbreak? So there have been those questions because there's been quite some delays. I don't know whether you have a comment on that one.
Well, absolutely. The campaigns really have to be implemented at before as soon as possible, I would say. And most of the time, the campaigns are really delayed and are implemented, I would say, after the peak of the outbreak. And the impact of the vaccination will be lower. If the campaign is not implemented on time, this is really and that's what we are facing too many times. I provided the indicators, and this is difficult, and I'm really interested, and we hear from the countries the difficulties to implement, and we know those indicators are really difficult to fulfill. But this is extremely important, and in all the training that we show, the campaign has to be implemented very early after the outbreak detection to have the best impact. And the impact is, of course, and there is less impact when it's when it's too late. Sorry.
Thank you. So there is a hand from Koku. So Koku, you can go ahead and ask your question quickly. Amarachi, if we can unmute Koku. Okay.
Thank you so much, Chair. Thank you for this great presentation. So my question is about Malawi. So I'm the principal technical officer for the surveillance and disease intelligence of Africa CDC. I'm based in Addis Ababa. So I know Africa CDC and WHO, we are supporting Malawi to end this cholera which is taking 2 years. So based on what is going on in Malawi, what kind of advice or guidance can you give us in terms of the implementation of our action plan?
That's very important.
Is that question directed to Malika on OCV, or it is a general question regarding all the interventions?
Yeah, because this is very broad, because the vaccination campaign still ongoing, and also the plan. This is a bit broad. So if I can have all those interventions, all those panelists give us their thoughts, their insights about the way we can reorganize ourselves to address this. I'm talking about as we have a kind of joint action, WHO, Africa CDC, but we're still struggling with this cholera since 2 years. So my question, I'm still asking myself, how should we organize ourselves to try to finish this outbreak?
Okay, maybe Malika, if you have a comment, then others will come in.
Okay, so as presented also by my colleagues, it's important to have a clear national cholera plan for Malawi, a clear identifications of the PAMIs and a target intervention for each of the PAMIs in Malawi. The work should already start. You are facing a lot of outbreaks. Maybe it's also time to have preventive measure and not, for example, an example of the vaccination, many outbreak response, and start to develop the national cholera plan with all the intervention in the PAMIs, whether it's for WASH activities, vaccination, case management, and everything. And I really invite you to develop the PAMIs and the response plan for all those activities. Regarding vaccination, we are ready to support you for any kind of intervention. Many doses were implemented and many campaigns have been implemented in Malawi several times. We need the good coverage also of 2 doses when we were providing 2 doses, good coverage of the implementation of the campaigns. We don't have a clear picture sometimes in Malawi of the coverage and everything, and that's also an issue that we need to look, is to ensure a good coverage of the 2 doses campaigns when we had the ability to provide 2 doses, and I can let my other colleagues respond.
Thank you very much, Malika. I'll call upon Professor Adebola to also respond. After Prof. Adebola, we'll have Dr. Joseph Serik to also comment. Prof, you can go ahead.
Yeah, okay, thank you very much. Just riding on where Malika finished from. For international organizations and all other organizations that are supporting countries, it's really to allow the country to take the lead on the National Cholera Response Plan and providing the technical guidance, the support as may be needed in terms of maybe operational finances and supplies to do this. So the National Cholera Plan, and not just developing the plan, but implementing it is the way to go if we want to control cholera. And just like the plan has highlighted, it's not just a function of the health department, it's a function of the multi-sectors within the country. We know how critical WASH is in terms of control of cholera. We are happy with what the vaccines do for us, but we all know it's a temporary measure. So in terms of sustainability, countries need to develop the plan, and not just develop the plan, but work on implementing it. And then organizations like WHO, Africa CDC, UNICEF, MSF, and so on, we support the countries to implement these plans.
Thank you, Prof. Thank you very much. Dr. Joseph Serik.
Yeah, thank you so much, Dr. Kapaya, and thanks a lot for the question. Yeah, just highlighting a bit on the role of the CSP and what has been done so far in Malawi. There have been very recently the validation of the PAMIs facilitated by WHO, and that is the first step towards a long-term process of developing national. You know, it's one thing to end the outbreak, it's another to really put a complete stop to future outbreaks from happening. And that is where the National Cholera Plan comes to play. And the country support platform plays a key role in supporting countries to really develop their national cholera plan. And we have been reaching out to country counterparts in Malawi to provide the needed support, and we're very much available to partner with other colleagues and other organizations like we're doing with the WHO and other key stakeholders in Malawi, so that we push the same momentum we carried in responding to the outbreak, we push it over towards developing a robust national cholera plan for Malawi towards ultimately controlling and ending cholera in Malawi. So I would really strongly suggest that Africa CDC can work very closely with other partners in country in Malawi to really support the Malawi government in driving this agenda forward. Yeah, thank you.
Thank you very much, Dr. Joseph. Very important points raised regarding development of the NCP for Malawi. And really, we need to help Malawi. Also, just to indicate that an AAR was done for Malawi, and a lot of lessons and challenges were identified. So I will encourage Africa CDC and all the other partners to look at the results of the AAR, because that will give us quite a lot of information regarding what we're supposed to do. But at the moment, let's work together, all of us partners, to support Malawi, especially at this point where we have very few cases. We can work on readiness. I think most of the times we want to respond, but we need to work at preparedness and readiness to make sure that the country is ready, and we should be able to actually manage if we are able to work in a multi-sectoral manner. So thank you very much. I see that there was a hand that was raised, but it has since dropped. And looking at the time, I would like to thank everyone that has participated, everyone that managed to join in. But I want to also, at this point in time, encourage everyone that we're having another very important webinar. In fact, we have 2 more webinars coming. The third one is coming next week on Thursday, on the 26th of October. This webinar is on case management. We'll look at case management, we'll look at IPC, we'll look at RCCE. Then we'll also discuss WASH, and we'll discuss the CATI approach that we've been talking about. So I am encouraging everyone here, please register for next week, same time. We'll be able to send an invitation to all of you so that you can join in next week, so that we can look at case management, even in countries that are now experiencing these outbreaks. And those that are yet to experience, it's the time for us to look at how we'll be able to respond, how we'll be able to prepare, and also WASH and CATI approach. So on behalf of Dr. Mori Keita and Dr. Miriam Nanyunja from the ISA Hub. I want to thank everyone for finding time to join in this very important webinar where we have actually learned a lot. Like was said in the opening remarks, so the WHO EPR cluster is committed to supporting countries, especially as we fight cholera in our region. So we encourage everyone to actually work with all the partners to ensure that we're able to eliminate cholera. So ladies and gentlemen, we have now come to the end of our webinar today. I wish you all the best and God bless you. Thank you.
Thank you, Dr. Fred. Thank you, everybody.
Thank you. Thank you very much.
Thanks, everyone. Bye.
Bye.
Take care.
Thank you. Bye.